Welcome to the Canon Medical Eye Care webinar. Today's webinar, you will hear from renowned experts in the field of vitreous, retina, and choroid. I would like to introduce the moderator for this evening, who as well will be the first speaker of tonight, Professor Paulo Eduardo Stanga. He specializes in medical and surgical retina, macular degeneration, diabetic retinopathy, vitreous floaters, cataracts, retinal laser, R&D new therapies, surgical technologies, and since 1993, he has also dedicated himself to the development and application of new outpatient and surgical therapies and technology. He has 32 years of experience in ophthalmology, and he's also head of the Retina Clinic in London. So please enjoy the evening, and the floor is yours, Paulo.
Thank you very much, Ori, for this invitation, and thank you very much to the Canon team for working with us. Welcome, everyone. Let me share with you our experience in imaging the peripheral retina using this novel technology, single capture wide field swab source OCT, with which we try to image the mid and peripheral retina. These are my commercial associations. I do not get an honorarium for this presentation. However, I do get equipment and research support. As ophthalmologists, we always rely on optometrists or other colleagues to receive patient referral, patients with retinal pathologies that need further investigation. However, both non-surgical retinal specialists, ophthalmologists, or optometrists always have the tools to assess beyond the posterior pole, that is the peripheral retina. Therefore, retinal pathologies sometimes may go unnoticed, and yet they may pose a strong threat to cause serious loss of vision or even blindness or need of surgery. The mid and peripheral vitreoretinal pathologies are usually difficult, if not impossible, to visualize unless you use indirect ophthalmoscopy, ideally with 360 degrees clear indentation. We have to remember that mid and peripheral vitreoretinal interface abnormalities span a wide range of retinal conditions. There are incidental findings like white without pressure, active management needing conditions like vitreoretinal traction, retinal breaks, and retinal detachment. The current approaches to detect peripheral retinal pathologies are based on dilated fundus examination. However, as we all know, most patients are only examined using a slit lamp and a non-contact handheld lens, as you can see here above and left on my screen. Here I'm doing indirect ophthalmoscopy with 360 degrees clear indentation, and this is the only way to image the retina up to the ora serrata. That's a movie at high speed and very gentle pressure on the eyelid. I do this on all of my patients that come to see me with new onset of floaters or symptoms of PVD, and I ask them to recline on the bed below. What is widefield? Widefield, and this is from our paper on the a recent paper from 2019 on the new classification and guidelines for widefield imaging. Widefield should be limited to images depicting retinal anatomy beyond the posterior pole, but posterior to the vortex vein ampulla in the four quadrants, a single image and not a montage. We talk about multimodal widefield imaging, and we should include now widefield OCT. So this is a patient, a diabetic patient. You can see here just an example of swab source, widefield OCT, 23 millimeter long. You see the red blood cells in the cortical vitreous. You see the bursa premacularis. You see the tabletop vitreous detachment. You see vitreous schisis. You see tractional retinoschisis. You see a thickened internal limiting membrane, distorted foveal profile, all, and of course the choroid, all in a single image. I started using OCT in 1998. That was the size device, time domain. We were very happy to get this sort of images, 400 A scans per second. In 2012, I started using swab source, and we realized that with swab source, we could easily image the vitreous. I received a prototype at the time of swab source to image the neuroretina, and when I imaged Professor McLeod's David McLeod's I noticed that we could image in vivo the bursa premacularis. We have to remember Worst's work, where he identified cisterns and canals, and for that he had to fill the eyes with milk or India ink. So we published this paper in 2014. So imaging the peripheral vitreoretinal interface in your retina may be a landmark achievement. Early recognition of lesions that need treatment or increased retinal detachment is essential. This can enhance clinical decision-making in suspicious images or lesions. It can change clinical management. We may reduce the number of patients suffering from retinal detachment and needing surgery, and it is important in an era of telemedicine. Let me show you the comparison of, amongst different various OCT techniques or technologies. This is a 12 millimeter long swab source. This is how we started with swab source. You can see the bursa premacularis, the spur, the space of Martigiani. The window depth is of 2.6 millimeters. Nowadays, with 23 millimeter long scans, which is what we get with the Canon Zephylio, that's 80 degrees, we get a window of 5.3 millimeter depth. So we can image deeper into the vitreous. We've already published a paper on this, Navigated Single Capture 3D and Cross-Sectional Widefield OCT of the mid and peripheral vitreoretinal interface with my co-authors here in London and co-authors at the Bascom Palmer. We compare that with also the findings with histopathology from a reference database. So we have to remember that with the Zephylio S1, we're using infrared light, 1060 nanometers infrared illumination, 100,000 A scans per second, a horizontal resolution of 30 microns, an actual one of 8 microns, 80 degrees viewing angle, and a 5.3 millimeter depth of window. So let's go to some examples, real life examples from my clinic where we believe that this device has changed management. A patient that attended the clinic with acute onset of floaters, history of retinal lattice, and this is what we're finding extremely interesting. Here you can see a vitreous attachment in the area of lattice. There are schitic changes in the area of lattice. You can also see the floaters. There are no tears. This is the actual lesion on widefield OCT. You can see even a tractional detachment. You can see the vitreous strands attached as we would expect from histopathology, perhaps a slightly elevated internal limiting membrane. This is in a patient with symptomatic lattice, with floaters and photopsia, no visible tears, no tears on the scans. So the scans are very reassuring in this case. It is always very useful, in my opinion, to see whether the vitreous is still attached to the edge of a tear or not, whether this could be the reason for residual photopsia. It is also important to know up to where the vitreous has detached in a patient with posterior vitreous detachment. This is a patient that came to for refractive surgery with my colleague, Professor Reinstein, and she was suffering of floaters. When I did the pre-ICL vitreoretinal examination, I noticed an area of lattice. Interestingly, when you see more in detail, you can see what looks like a tear, a couple of tears in lattice, a hole. As we know, most holes in lattice are not full thickness. So is this a real full thickness hole or not? Well, we can clearly see that there is an area of detachment. There is a full thickness hole. The vitreous is attached. This is another tear. There are several areas where the retina is detached along this area of peripheral lattice. I offer this patient laser retinopexy all around that area. This is a more in detail view. You can clearly see the vitreoretinal attachment and the elevated retina. This is a patient that has already undergone laser retinopexy around a subclinical supratemporal retinal detachment with various tears. You can see signs of chronicity, and the signs of chronicity are the schitic changes. So it's good to reassure the patient that this is a chronic lesion. It still, of course, needed a treatment. Now, this was one of the very first cases where we saw the significant beneficial effect of this technology. There's a patient with symptoms of acute PVD, underwent ultra-widefield imaging. I looked at the ultra-widefield imaging. I didn't see anything special. By microscopy, I thought everything was fine. When I'm doing indirect ophthalmoscopy, I see that this area could be slightly elevated, but very, very, very shallowly elevated. And when I did OCT scan, this is navigated. So that's with the patient looking up. And this is a 3D cube placed in that region. You can clearly see that the retina is elevated. And not only is elevated, there is a full thickness tear. And you can see the vitreous attached and pulling, being this a superior lesion with an attachment and photopsia. Certainly this, in my opinion, needs treatment. This is a 3D rendering of the lesion. I've surrounded all that area with laser. After the laser, it's more obvious, more easily visible that there is subretinal fluid. And this is a 3D rendering of that area. You can see the vitreous attached and starting to peel off and pulling from the tear. The horizontal lines are artifact. This is movement because we are scanning very far out into the periphery. This is another example of a vitreous attachment to the edge of a tear. So this is very useful for the patient to understand what the reason why they've suffered a tear, why they are at risk of developing a retinal detachment. This is very different. This is a patient with an operculated round tear. This is the free-floating operculum. You can see a pale area that appears to be fluid. However, when you scan that lesion very peripherally, you can see that not only there's no vitreoretinal attachment, but also that there is no fluid. So some people do choose to treat, some people choose not to treat. This is the 3D rendering, and this is a shadow cast by the operculum. Now, very commonly, we see these pigmented lesions, and I've usually been told when I was in training, these are pigmented retinal tears. You don't need to do anything. The pigmentation is the same as PEXI. Well, it's important to do OCT because this is, in my opinion, a vitreoretinal tuft. There's no tear there. So we have peace of mind that this lesion does certainly not need treatment. And in this patient, we can easily see the edge of the PVD. So we can see that the PVD is almost, if not complete. So very reassuring for the patient. We know PVD is a progressive process. Now, this patient underwent treatment for what he was told to be a retinal detachment. This treatment was done in, if I remember correctly, in Singapore. Now, very strong laser. We scanned this area. The retina was completely flat, so no detachment. And usually you don't cure a retinal detachment with laser. However, this was very interesting. There was this sort of fibrotic plug sitting over the retina that appeared to be flat. However, look at how interesting the cross-sectional view of this area, of this finding is. And this is the 3D rendering. It looks like a giant vitreoretinal tuft, and you can see the vitreous attached, but it's reassuring that there's no rhegmatogenous lesion associated. And we see it as flat. However, it is certainly not flat in real life. This is another case where we changed management thanks to this technology. What appeared to be a small tear, sorry, in a symptomatic patient with PVD, and what appeared to be subretinal fluid. However, OCTs navigated peripheral OCT showed that there's no vitreous attachment. Maybe the vitreous had pulled at some stage, and there is schitic change here, which is what we see appearing as subretinal fluid. So no full thickness hole, no subretinal fluid, no need of treatment in a lesion that without these scans, I would have treated thinking that this was a tear with subretinal fluid. And this is the 3D rendering. White without pressure, we commonly see this type of lesions, especially in younger patients. And here you can see what white without pressure is, increased collagen in front of the retina. We can clearly see increased collagen in the attached vitreous. And another example of a vitreous tuft, here no vitreoretinal attachment, increased collagen there, and an indent in the retina rather than a protrusion of the retina. This is a lesion that we see very often, commonly referred to differentiate from retinal detachment. Obviously, if you are a retinal surgeon, you would think, well, perhaps this is schisis. There's no demarcation line. It's very elevated because of the configuration. However, for the non-retina specialist, having a scan, being able to see the outer leaf attached to the RPE and the internal striations, the stretched fibers of Henle is very reassuring with regards to reaching a diagnosis. This is the famous peau d'orange or orange skin as it's been described. And this is a 3D rendering of that same area of schisis. Very reassuring, and of course, no treatment is necessary. This is a patient that had a retinal tear, superior retinal tear in the fellow eye. And of course, we examined both eyes, superior lattice. And the interesting thing is how we can diagnose this, assess the status of the vitreous attachment or the presence or absence of PVD with widefield OCT. As you can see, significant number of vitreous floaters. You can see the vitreous is partially detached, still attached to the optic nerve head. So I showed this is September 2020. I showed this scan to the patient and I said, please do bear in mind that the vitreous in your left eye is still attached. You will most likely go through symptoms. I need to see you as soon as you develop symptoms. So she rings me a month and a half later, 9:30 p.m. on a Friday. I say, come on Saturday morning. And you can see there is a large tear that ruptured even the blood vessel along the edge of lattice, which we could easily treat. And here you can see the 3D rendering. You can see the vitreous attachment. You can see that there is a little bit of subretinal fluid already. So there is the beginning of a subclinical detachment, as you can see here, more than 2 disc areas of subretinal fluid. So again, very helpful. You can clearly see here the presence of a posterior vitreous detachment. And you can see that that pigmented lesion is a vitreoretinal tuft. However, there isn't a full PVD in this patient. The vitreous is still attached at the optic nerve head. So it's important for patients to understand this. This is a patient that had several surgeries elsewhere to repair a retinal detachment that started similar to the patient that I showed you with a superior tear. And interesting, you see this strand of fibrosis that remained after fluid was, after silicone oil was removed, peripheral PVR. So here you can see a wide field single scan topography map, which is very useful to explain to the patient and for us to understand why there's no recovery of vision. See how thin the inferior retina is. And you can see that the inferior retina, the retina here, is completely attached. And this is the 3D rendering showing that stock of fibrosis. The fellow eye of this same patient with wide angle single scan topography, you can easily see that there is myopic schisis in the nasal retina. And I'm getting close to the end of my presentation. As some of you know, I've done a lot of work with the Argus 2 implant. And this is one of the patients I operated. I operated this patient 9 years ago. And I want to show with this the strength of the penetration of this technology. We're going through the array. These are the electrodes. We can see the thinning of the retina, the schitic or degenerative changes in the retina under the array. And we can see epiretinal membrane between the array and the neuroretina. Look how thin the retina is and partial detachment of the internal limiting membrane. So, as a conclusion, if we really want to examine the retina, we need to examine the retina aura to aura. Slit lamp biomicroscopy is not enough. You can only see the aura in the model eyes at ophthalmology shows. Otherwise, we need something else. Peripheral retinal imaging has an increasingly important role in screening, diagnosing, monitoring, and treating retinal diseases. And not only to rule out retinal tears, but also, for example, in diabetics. Widefield swab source OCT has become essential in our practice. It successfully assists in the diagnosis of not only vitreoretinal pathologies in the periphery, but also in the objective assessment of PVD. It's very difficult to sometimes assess PVD. It's a new technology that's also essential to diagnose PVD in the fellow eye and counsel the patient appropriately. We always assess the fellow eye. It's important to tell the patient whether they have a PVD or not in the other eye, whether they need to expect a PVD or not. Using this new technology and a scanning technique called navigation, where we ask the patient to look in different directions and we move and we position the scan in that area, it is possible to obtain high quality and clinically meaningful images of the peripheral retina and the vitreoretinal interface. This technology, in our opinion, is helpful in the decision-making process of indicating timing for a referral, whether it's urgent or not, or treatment, particularly in an era of telemedicine, or when there's no access to a surgical retina specialist, or indirect ophthalmoscopy with 360-degree scleral indentation. I would like to thank Ursula Reinstein, my retina research associate, Eric Grabowska, study coordinator, Pooja Vatas, lead retina nurse, Nasma, retina optometrist, Francia Villa, our clinic manager, of course, Ori Sahabi from Canon Medical Systems, with whom we work very closely. And don't worry, we will get your peripheral retinas. Thank you very much. So our next speaker is Sandrine Zweifel. Sandrine is Vice Chair of the Department of Ophthalmology at the University Hospital in Zurich, Switzerland. He's also head of the Medical Retina Unit at the Department of Ophthalmology. She's responsible for the management of medical retina, injection clinic, cataract service of patients with retinal diseases, and is involved in training of medical students and registrars in ophthalmology. Sandrine will present on the feasibility and clinical utility of ultra-wide field OCT angiography. Sandrine, thank you very much for joining us.
Paulo, thank you very much for this kind introduction. It's really a pleasure to be part of this Canon webinar. Here you see my financial disclosures. None are relevant to the topic of this presentation. Let me start with a case. This is a 77-year-old male with a history of coronary artery disease and multiple cardiovascular risk factors, including diabetes, arterial hypertension, and dyslipidemia. I'm sure you have already noticed this full thickness retinal hole in the temporal far periphery. In addition, you can observe increased hyperreflectivity of the inner retinal layers, which is a sign of ischemia, and there is also retinal thickening and some amount of fluid. Ultra-wide field fundus color photography demonstrates that actually this retinal tear is sufficiently surrounded by pigmented laser scars. However, you probably have noticed that some of the vessels are hardly perfused. I didn't tell you actually the whole story, because what you see here is ex vivo imaging. Here you see an eye of a donor which was fixated in formalin and placed in a custom-made holder, which you see here on the right side of the image. The custom-made holder incorporates a +60 diopter lens, which compensates for the missing refraction by the cornea and the lens. Of course, the quality of the ex vivo images is dependent on the time between the death of the donor and the beginning of fixation. So we had the opportunity to test the Xefilio device for a period of 10 weeks. We scanned 156 patients during our normal clinical routine. 39 patients who had ultra-wide field fluorescein angiography scheduled, they agreed also to be scanned using the Xefilio device. Here you see the settings which we usually used. We used the pattern size of 23 by 20 millimeter, both for the OCT and for the OCT angiography. Here you see that we scanned patients with a variety of ocular disorders. Most frequent diseases included AMD, central serous, diabetic retinopathy, vascular occlusion, uveitis cases, but also more rare cases like sickle cell retinopathy and others. So let me show now really a clinical case. This is a 74-year-old patient who was sent to us for evaluation of a new unclear gray prominent lesion in the far periphery of the left eye. Visual acuity was normal. Here you see actually the OCT scan of the macular area, which was normal. But let us look at this lesion in the far periphery. We did a wide field or ultra wide field fluorescein angiography, and as you can see here, there is rarefication of the capillary network, also some non-perfusion area and leakage. In this patient, we were also able actually to image this lesion, which is in the far periphery, using the Xefilio device. And you can see here that the device has detected some flow in this lesion, and the lesion is actually located intraretinal. This is something you can't depict when you do fluorescein angiography only. So this is a retinal vasoproliferative tumor. They are usually benign. Most commonly, they are primary and occur as a solitary lesion. They can also be secondary to pre-existing ocular disease, including inflammatory, vascular, traumatic, dystrophic, and degenerative ocular disease. The treatment strategies are usually watchful waiting for like small lesions, or you can also do photodynamic therapy. The patient actually agreed to do a PDT. We did double exposure PDT. That was in the beginning of this year, as Visudyne was still possible to get. Let me show you a second case. This is a 61-year-old symptomatic myopic patient with a horseshoe retinal tear. Of course, we did laser retinopathy in this patient. 2 months later, the patient presented himself again at our emergency department because he developed vitreous hemorrhage. After a few weeks, when the hemorrhage actually resolved partially, we did scan the patient using widefield OCTA, as you can see here. There are some imaging artifacts, but what you can nicely see here, that there is a full thickness retinal hole with a localized retinal detachment. And when you look a little bit more carefully, as also nicely shown by Professor Stanga, you can see here that there is still some traction. So this is a tractional detachment. The vitreoretina is attached. And in this patient, we did vitrectomy and the eye was filled with silicone oil. Let us focus now on diabetic patients. In a small study, we wanted to test the diagnostic performance of this novel widefield Vitreous OCT angiography device in detecting retinal non-perfusion and neovascularization in eyes with diabetic retinopathy, and to compare it with the standard of care imaging method, the ultra-widefield fluorescein angiography. Ultra-widefield fluorescein angiography was performed with the Optos device. Here we see the inclusion and exclusion criteria. Of course, we excluded patients who had panretinal photocoagulation in their history. The pattern size for the widefield OCT angiography images, it consisted of a single scan captured at 23 by 20 millimeter. And we did quantitative and also qualitative analysis. You already heard about this nice paper. What are actually the challenges when you have to think about obtaining quantitative measurements or also qualitative measurements in widefield images? First, of course, you need to have a consensus definition. When do you speak about wide field or mid periphery, and when do you talk about the far periphery or ultra wide field? We tried to use this classification doing a qualitative analysis of the presence and localization of non-perfusion area, as you can see here. So this is posterior pole, mid periphery, and the far periphery. And for example, in this case, you have non-perfusion area in all the subfields. And when you look at retinal neovascularization, you can also detect retinal neovascularization in all this area. We also did a quantitative analysis, and we calculated the ischemic index based on fluorescein angiography. This was performed as follows. The total retinal area evaluable on a single fovea-centered ultra-wide field FFA image was marked using the freehand region of interest tool of the Optos software. The area of non-perfusion was calculated as the sum of all non-perfused area manually encircled using the same annotation tool as for the total retinal area calculation. And then you can calculate, when you have the total evaluable area over the non-perfusion area, then you have the ratio which was calculated for all cases and referred to as ischemic index. Here you see again this patient with the Optos fluorescein angiography and overlaid the wide field single scan OCT angiography. We also did qualitative analysis for the wide field OCT angiography. So we looked at non-ischemic area and retinal neovascularization Of course, this was not only applicable for posterior pole and mid-periphery. We did quantitative analysis of the 23 by 20 millimeter wide field OCTA, similarly, of course, to other studies. But of course, you have to consider here that there are some limitations when you do quantitative analysis, because especially in the periphery here, there may be some artifacts. Let me show you the preliminary results. We scanned 16 eyes. They had a mean age of about 68 years. Type 1 and type 2 diabetes were included, as well as non-high-risk proliferative diabetic retinopathy. So what do you need to consider when you look at assessment, qualitative but also quantitative, of non-perfusion and retinal neovascularization? When you look at the qualitative analysis, it's noteworthy that when you look at the fluorescein angiography, it might be even less accurate in comparison to widefield OCT angiography in detecting retinal non-perfusion at the posterior pole due to masking the macular pigment on dye signal. Of course, this is also depending on the FA device you are using. When you look at qualitative analysis, of course, we looked both widefield OCTA and ultra-widefield fluorescein angiography. Both were quite good and able to detect retinal non-perfusion in the mid-periphery. But when you, of course, look at the far periphery, for example, in one of the eye, the OCT angiography was not able to detect. We also did quantitative analysis, so Spearman's test did not show a significant correlation between the ultra-widefield FFA ischemic index and the vessel density using OCT angiography. You can say this may indicate that the vessel density detected at the posterior pole or mid-periphery is not representative regarding to the overall retinal circulation integrity. But of course, what we have to consider here is that the sample size is very small, and it's actually too small to make any meaningful statistics. In conclusion, non-invasive wide-field OCT angiography offers a great potential for the management of many retinal diseases, including diabetic retinopathy. This new imaging modality seems to be useful in clinical daily routine to lower the number of invasive examinations. However, in a small percentage, OCT angiography images cannot be reliably graded for the presence of non-perfusion areas and neovascularization, and in these cases, we still need conventional fluorescein angiography. Quantitative analysis of larger fields of OCT images are not always reliable, so you should be careful. However, qualitative analysis of retinal non-perfusion and neovascularization using OCTA seems more promising. In the future, larger longitudinal studies providing also insight into how well OCTA capillary defect correlates also with the periphery and with DR progression are needed. Before I finish my presentation, I would like to thank for the continuing support of our research team here in Zurich. Especially, I would like to thank Anahita Baika and Tomasi Baci, who helped a lot to acquire and also analyze the data. And of course, I would like to thank you for your attention.
Thank you very much, Sandrine, for that excellent presentation. I remind everyone that we'll take questions at the very end of this webinar. It is great pleasure to present Dr. Spaide, Rick Spaide. Rick is very well known to all of us and does not need much introduction. Rick, as you know, is a New York ophthalmologist at the Vitreous Retina Macular Consultants of New York. He specializes, of course, in retinal diseases of the and the vitreous. His particular interests include retinal surgery, macular degeneration, macular holes, pucker, diabetic retinopathy, and intraocular inflammation. He has published more than 300 articles, 50 book chapters, 9 books about the diagnosis and treatment of retinal diseases. He has given lectures around the world, and every year he gets another award. So, Rick, it's with great pleasure that we invite you to speak. Thank you very much for joining us.
Hello, my name is Richard Spaide, and I'd like to present venous overload choroidopathy. Here are my disclosures. Using EDI-OCT, we showed that the choroid was thick in patients with central serous chorioretinopathy, not only in their involved eye, but also in their fellow eye. In addition, we showed that Vogt-Koyanagi-Harada disease has a thick choroid. From this, some people developed the concept of pachychoroid, or thick choroid, but for some reason or another, never included Vogt-Koyanagi-Harada disease. To get an idea about what really entailed pachychoroid and its entities, I looked at all papers published September 2013 until April 2020. There are 44 papers specifically about pachychoroid. 19 of these papers had no definition. 25 papers used 18 different definitions. Pachyvessels were stated to be an important component of pachychoroid. I looked at 22 papers concerning pachyvessels. 7 papers had no definition at all. 4 papers had a simple definition of just dilated vessels. 11 papers had 7 different complex definitions for pachyvessels. Well, what about Vogt-Koyanagi-Harada syndrome, a cause of a thick choroid? Or what about these causes of a thick choroid? Or these causes? Or these causes? None of these are considered to be part of the pachychoroid spectrum. The definition of pachychoroid was changed. It was said that choroid did not have to be thick for the patient to have pachychoroid. Choroidal vascular hyperpermeability was said to be important. If that's true, then what about these conditions? They all cause choroidal vascular hyperpermeability, as do these. What about these? All of them cause hyperpermeability in the choroid. None of them are in the pachychoroid spectrum. It can be seen that pachychoroid and pachychoroid spectrum are incomplete and poorly defined, at least lacks a thematic focus. Is it a spectrum? If most of the disease that could be in it are left out, is it really a theory? After all, it would be good to have a mechanistic theory of disease. This will help us in understanding the disease, allow us to make predictions about the disease pathophysiology, and it would help guide development of future treatments. Let's look at a normal ICG angiogram. Notice there's independent venous drainage into vortex vein systems that do not communicate with each other. They are separated by watershed zones. The vertical watershed zone is shown as a white dashed line. Horizontal watershed zone is a yellow dashed line. Let's look at the control of venous outflow from the choroid. It's very interesting. The arterial pressure comes into the choroid at about 70% of the systemic blood pressure. The pressure in the choroidal veins is about 2 to 3 millimeters of mercury more than the intraocular pressure. The blood leaves the vortex by means of the vortex veins, and the pressure in the vortex veins is only about 2 to 3 millimeters of mercury. You would think that if you increase the intraocular pressure by a few millimeters of mercury, you would cause the collapse of the choroidal blood vessels, since the blood pressure in the choroidal veins is only 2 to 3 millimeters of mercury higher than the intraocular pressure. But that would be exactly wrong. When the intraocular pressure is increased, the pressure in the choroidal vein increases by a similar amount and always remains 2 to 3 millimeters more than the intraocular pressure. This continues until the point where the intraocular pressure is approximately equal to the systolic blood pressure. There appears to be a various resistance to venous outflow, and it's entirely passive and can be controlled by the intraocular pressure, and it appears to occur at the exit site for the vortex veins leaving the eye. And that forms the basis of what's called a Starling resistor, and this is I described in a paper about choroidal blood flow. The interesting thing about the outflow path for the vein is it follows the same pathway that we would make for a self-sealing vitrectomy incision. where there used to be the idea that a self-sealing vitrectomy incision would be closed in part by the intraocular pressure pushing against that tunnel. Well, that same force would be placed against the vein leaving the eye. Here's a patient with central serous chorioretinopathy. Try to look to see where there is a watershed zone. It's not possible because this patient has very prominent intervortex venous anastomoses, highlighted in yellow here. Here's another patient with central serous chorioretinopathy. Note the very large venous anastomoses that are present between the vortex vein systems. Now, if we did a horizontal B-scan across the macula, we would see large vessels. Maybe some people would call these pachyvessels, I don't know. But I think what people were talking about when they're talking about pachyvessels were actually these anastomotic vessels. Scleral thickness is an interesting component in eyes. Hideki Koizumi and his team found that the anterior sclera and central serous had increased thickness and postulated that the posterior sclera also was increasingly thick in central serous patients. It's thought that excess fluid produced in the choroid diffuses through the sclera. The choroid has no functional lymphatics to remove this fluid. In eyes with thicker scleras, you can imagine that there would be a greater difficulty in fluid leaving through the posterior sclera. Central serous eyes have thicker scleras than do normal eyes. You can imagine that there will be more regulatory force on the vortex vein as it leaves the eye going through a thicker sclera than there would be going through a thinner sclera. Of interest is males have a thicker sclera than do females, so this would affect both the outflow of blood through the vortex vein as well as the removal of fluid from the posterior pole of the eye through the posterior sclera. Peripapillary pachychoroid syndrome is defined as intra-subretinal fluid in the nasal macular region associated with a thicker choroid in the nasal macula than you would expect for that person's age. Lots of stuff could fulfill this definition, but I think what they were talking about was this. Here's an eye with peripapillary pachychoroid syndrome. Note the enormous number of anastomotic blood vessels that seem to congregate mostly around the optic nerve. They're highlighted in yellow in this picture, and here's an enlargement of those vessels. So the intervortex venous anastomosis occur in central serous predominantly in the macular region and in peripapillary pachychoroid syndrome around the nerve. The anastomotic vessels, I think, are likely to be what people thought were pachyvessels. Here's a patient who had central serous, went on to have neovascularization. This is an indocyanine green angiogram. You don't see the neovascularization quite so well, but it's at where the arrow was. Notice the large intervortex venous anastomosis. They're really quite giant. Here's a patient who had central serous chorioretinopathy, went on to have polypoidal choroidal vasculopathy. Once again, this patient had intervortex venous anastomoses. Let's look at some other diseases that show similar traits. Here's a patient, courtesy of Eduardo Gil, who had carotid cavernous sinus fistula. These patients may have serous detachments, much in the same way that patients with central serous can have. Notice the very prominent intervortex venous anastomoses. Pulmonary hypertension causes elevated pulmonary vascular resistance, chronic right heart dysfunction, elevated systemic venous pressure. Here's a case from David Greenfield in a patient with pulmonary hypertension showing large episcleral veins, serous attachment of the macula, thick choroid, and prominent intervortex venous anastomoses. Stenosis of the transverse sinus in the brain causes an impediment of venous outflow and increased venous pressure in the brain. This venous pressure is conducted back into the eye. In addition, there's increased intracranial pressure. These slides are courtesy of Vishal Gupta. This patient has transverse sinus stenosis, increased intracranial pressure, swollen optic nerves, and dilated veins. This patient has descending tracts of fluid, more easily seen on autofluorescence imaging. And you see the prominent number of intervortex venous anastomoses, as shown here, and late hyperpermeability. This patient had a thick choroid, retinal pigment epithelial detachments, and serous detachments of the macula. Here's a patient with a circumscribed choroidal hemangioma. These lesions have hyperdynamic flow, and that flow has to be drained out somewhere. And notice that this patient has a large number of intervortex venous anastomoses. The patient also demonstrates hyperpermeability in the later phases of the angiogram. Systemic diseases may offer paradigms for what's going on in the choroid. Degenerative diseases of the venous system are extremely common diseases in humans. Varicose veins are found in 84% of people over age 18. Pelvic congestion syndrome is found in 15% of women. We're all familiar with esophageal varicosities seen in cirrhosis. Varicosities can also happen in the brain, particularly in areas in which there's a lesion that has a high flow, such as the AVM. The veins draining that may form varicoceles. In chronic venous insufficiency, there's increased venous pressure, dilation of larger veins, formation of anastomoses, and overloading of the capillaries. These capillaries become dilated, elongated, they suffer damage, and also leak. The common elements with eye disease is that the choroid appears to have abnormalities of venous outflow, enlargement of the veins, anastomosis, and capillary dysfunction, much in the same way that we would see in varicose veins, say in the leg. Venous overload choroidopathy may share some of the mechanistic pathophysiologic changes that we see in chronic venous insufficiency in other organ systems of the body. This could lead to venous dilation, remodeling, anastomosis formation, and then to capillary leakage manifested by serous detachment of the macula and also by choroidal thickening, damage to the choria capillaris, and eventual obliteration of some of the blood vessels in the choria capillaris, which can lead to secondary complications such as choroidal neovascularization. This venous overload choroidopathy can be due to extrinsic causes such as carotid cavernous sinus fistula or vortex vein occlusion or space flight associated neuroocular syndrome, or intrinsic causes such as central serous chorioretinopathy, peripapillary capillary syndrome, or circumscribed choroidal hemangiomas. There currently is a paper concerning venous overload choroidopathy and related diseases in progress in retinal eye research. It's open source and includes a bunch of great co-authors. I welcome you to download and read this article. Widefield OCT would be great to evaluate venous overload choroidopathy. It offers the potential to be able to look at large choroidal veins and their interconnections without having to use ICG. But to do so, you need to be able to segment the larger choroidal veins in OCTs. A common way to segment a choroid is to measure down a certain distance from Bruch's membrane and then make the segmentation slab there. This would work in areas of thinner choroid, but in areas of thicker choroid, it would not correctly segment the larger veins. We know that the choroid is thicker in the posterior pole than it is in the periphery. If we segment a constant distance away from the Bruch's membrane in the periphery, in the posterior pole, we would not, therefore, segment the larger veins. An alternate method would be to segment from the choroidal scleral junction. In this way, we would correctly segment the larger choroidal veins everywhere around the eye, in areas of thinner choroid and thicker choroid, and this would help us see the blood vessels better. I made this suggestion to Canon, and they're working on this improved segmentation method. This new method would greatly expand our ability to evaluate venous overload choroidopathy and help evaluate patients without the need for injections of dye. Thank you.
Thank you very much, Rick, for that fantastic presentation. So the floor is open for questions. Let's see whether we don't have much time, but we do have time for some questions. Let's see if the audience submits some. Here is the first one. Would you recommend and include widefield OCTA for your daily practice? If yes, when do you think that fluorescein will still be required? I think that's a very pertinent question. Let's start with Sandrine and then Rick.
Yes, thank you very much for this important question. As I mentioned, we actually use the Xevideo device just in like normal clinical daily routine. And it's, let's say, very helpful, for example, for diabetic patients, as I have shown. I think for some patients, you still will need to do a dye test, especially, let's say, for like baseline evaluation in, for example, uveitic disorders or white dot syndromes, because you also have additional information when you do a dye invasive test. But overall, as I showed, we did usually just like single scan OCT angiography, which encompasses a field of 23 to 20 millimeters, and it was very easily to acquire.
Rick?
I agree with Sandrine. There's certain uses for dye-based angiography that are going to be hard to replace with any kind of OCT angiography, because dye-based angiography not only tells us the anatomy of something, it also tells a little bit about physiology. So when we see leakage of dye from vessels, say incompetent vessels in diabetic retinopathy, or that caused by inflammatory disease, that tells us something about the physiology of those blood vessels, that physiology has been altered by the disease process. That said, if you think about it, a lot of times we do fluorescein angiography, not because we don't know what it's going to show. Oftentimes there's a way to document what's there.
Mm-hmm.
So if we look at a patient with neovascularization, choroidal neovascularization, can you diagnose that just from an OCT? Sure. But a lot of times we end up doing dye-based angiography just because we're going to embark on some long course of anti-VEGF treatment, and we wouldn't have like adequate documentation in case somebody comes back and says, what's your proof that it really was there? So some of it's going to be substitution effect, where I think that a high quality OCT can replace fluorescein. And in some cases, in some diseases, we're still going to be using dye-based angiography.
Sandrine, I've got a question for you. In which retinal disorders ultra-widefield fluorescein angiography do you think will be replaced by OCTA?
I think Rick Spaide already covered this topic a little bit. I think, let's say, for example, for follow-up examination, including vascular occlusion, including diabetic retinopathy, I don't think it will be necessary to repeat a dye test again. Also, like, let's say, for the evaluation of like more rare disease, including sickle cell retinopathy, where we really just have to detect if there is still like area of non-perfusion or retinal neovascularization. I think wide field OCT angiography will be a very good alternative. As I said, like for quantitative analysis, and when we think about, let's say, trials where nowadays OCT angiography is included more as an exploratory imaging method, there is like still a long road to go, and there needs to be like an improvement, especially when you analyze wider fields.
Thank you, Sandrine. Rick, you've presented some fantastic cases with systemic vascular disease. If we move to a more common diagnosis like CSR, there's a question from Dr. Gabor Somfei. How do these findings change the treatment of CSR?
Well, yeah, you know, the basis of our current treatment was that we, in the 1990s, we saw that ICG demonstrated hyperpermeability in the choroid. Then we showed that with OCT, the choroid was thick. And with PDT, which we were doing at the time, that when you did PDT on choroidal neovascularization, you could see where the PDT was because it left a dark spot, because it kind of injured the blood vessels. So if it was hyperpermeable during ICG, and if it gets hypofluorescent with PDT, we thought maybe we can treat CSC, central serous, with photodynamic therapy. So we did that, and it worked. And that was the kind of the now the worldwide treatment for central serous. But to go to the next level, we can't do the same thing again. We can't say, oh, there's, we're going to treat again with hyperpermeability. We're just doing the same thing. So we have to have better ideas to go forward from our current state now. And we're doing a lot of different studies actually on central serous currently. But if you understand the blood flow abnormalities, and there's some other structural things that I can't talk about yet because the studies are not done. I think it's going to change the way we think a lot about central serous. It's going to open up, once you have a better idea of the disease, it gives the idea about how to treat it then becomes more obvious.
Thank you. Sandrine, a question from you, from Gabor. How does segmentation perform in the periphery? How reliable are the readings, and is it difficult for the subjects to comply?
Gabor, thank you very much for this question. It's actually, let's say, for people who have not good visual acuity, it's not so easy to hold the fixation. And therefore, there are like artifacts, especially in the peripheral part. Regarding, I mean, we analyzed for the diabetic patient just the superficial capillary network. In the deeper capillary network, there was, let's say, even more imaging artifacts. But as I said, I think the device is very helpful to use it as a tool where you can easily do some qualitative analysis. And this can be also done even if you have, like, let's say, some blinking artifacts, because usually it's still possible to evaluate, for example, retinal neovascularization. It was, we compared actually, we said like the fluorescein angiography is like the gold standard or the ground truth, and OCT angiography for the posterior pole and also for the mid-periphery was as good as fluorescein angiography.
Can I just add to that to a certain extent? Fluorescein angiography was first done in the late 1950s in cats, even to the point where videos were done. And then the first human one was published in 1961. And we have therefore had fluorescein angiography, at least in common use, for 50 years. And it took a while for people to warm up to that. And Gass was really like the one who kind of linked fluorescein angiography with other things to try to understand macular diseases, and that was in the late 60s. ICG, and OCT angiography has been really around only for a few years, and we already have things that can kind of compete with fluorescein angiography, which has been around for half a century. So that's a remarkable thing. And if you look at that rate of growth and change over time, it's kind of what's going to be in 10 years. It's going to be like way better than it's now.
Agreed.
Following on that, how do you use OCT angiography in your everyday practice? Not when you're doing a piece of research, every day. Patient that comes to see you with loss of central vision, distortion of central vision. How do you use OCTA?
Do you want to answer that, or should I answer that first? I can answer first. So imagine you're playing tennis, and then you've got a forehand, and then you learn a backhand. And if people say, well, what do you use a backhand for? Well, could that be good for? And it's actually, if you you play tennis, it's kind of good to have both, right? And the same thing with OCT angiography. The more you use it, it's kind of like part of your everyday clinical routine. And there's so many things you can see on it, you kind of don't even think twice about doing it. And it's, OCT angiography now is like a expensive or special add-on sometimes to some machines. But when computers were first used for word processing, a spell checker was an expensive add-on, and now spell checkers are in every program. And I think it's just going to be like that everybody who gets OCT is going to get OCT angiography in the future, just because it's just part of OCT.
Maybe I can add something, Paulo. I mean, for example, let's say for patients with neovascular AMD, if there is OCT angiography is able actually to visualize the neovascular membrane, and you have in structural OCT associated fluid, we usually don't anymore perform also fluorescein angiography as a baseline diagnostic. So I think for some cases, you know, OCT angiography already could or have replaced FA. But of course, when you, let's say, when you diagnose a type 3 macular neovascular lesion, maybe it's not always so easy to detect the intraretinal flow using OCTA. So of course, there maybe the gold standard is still to do an IFG, but very often in combination with structural OCT, you are actually able to make correct and reliable diagnosis.
Question for both of you. What do you think about AI denoise? How useful do you think it is? Rick, you start.
So the images are just frankly sometimes a little bit noisy with the OCT, and also the resolution is a little bit less than maybe for OCT that you're used to. I think because the scan pattern is a little bit looser for the, especially for the bigger ones. So I think that AI denoising is very helpful. We were very careful about looking at that to make sure that it wasn't making up blood vessels or the like. And it doesn't seem to be like that at all. So I commonly use the AI denoising.
Sandrine?
Yes, same for me. Maybe, you know, like the lower resolution has also something together with that. For example, for the OCTA, it's just like the twice they do the rescanning. Where for other devices you do more than twice. But of course, it's a larger field. So you have 23 by 20 millimeter just by one single scan, and the larger field you have, the longer it takes. And when it takes longer, actually, the patient has to, you know, there is a higher risk of artifacts due to moving.
Well, that's a bit answering my question. My next question, which was, if you have, for both of you, what tricks do you have for patients with, for example, for diabetic with no vision, when you want to do an OCTA?
I get to start first, maybe. The ways that you gain speed and is to use a smaller scan pattern. So having that giant scan is super good if the patient can fixate. But there's not much tolerance in the way the machine can track or do things on such a big scan, and it's more, I think it's more susceptible to the just motion artifact. So if you're having trouble, just use a smaller scan. You can tile them up, and just like we used to do in fundus cameras, take a bunch of pictures and you still end up with a pretty good picture. You know, neovascularization is kind of predictable on where it occurs. We can scan with a little intelligence on our part to look where we want to know, and we want to know about edema, so we can look for that too.
So my last question to both of you. Christmas is coming. Very soon. Fast. In New York, you are already
Santa Claus?
So,
Paulo Claus?
what would you like to see? How would you like to see OCTA evolve in the next year?
So now I thought I can say something for Christmas for the Canon people, that we actually get back the device for a longer time. But you want to do what needs to be improved. I think, as Rick Spaide said, like the improvement and the advancements in technology is like very, very fast. And of course, we would like to see higher accurability when we do like quantitative measurements as well, because this would allow us to do like longitudinal studies, that you have follow-ups with the precise location of prior scan visits. And this would probably also allow to predict, like, for example, for diabetics patients or vein occlusion patients, you know, who will develop and progress to a proliferative diabetic retinopathy.
Great.
But like the Christmas present, just that Canon heard it again.
I think they heard you.
Longer.
I think they heard you, Sandrine.
We could even do some studies together with New Yorker.
We'll start the collection for you.
Yeah.
So for my Christmas present, I wish Sandrine would get the OCT again. No, that's. I think that you can split things for Christmas presents into multiple different sections. There's a hardware-driven kind of thing, which if you think about it, people make hardware platforms. They stay relatively stable for some years because it's so expensive to make a hardware platform. And everything that happens over at least some subsequent years after that, it's all software-driven. So if you think about, there's a lot of information in OCT, I think that we're not adequately using. There's ways to look at spectral splits, where we look at the parts of the spectrum of the OCT, and we can derive blood oxygenation levels from that. And that should be possible with swept source OCT. I'm not sure if Canon's working on that, but I think that would be an interesting thing to work on. There's certainly the AI thing in terms of image quality improvement is definitely possible. And finally, what Sandrine was talking about, using the data that's in, say, one or a sequence of imaging then to predict the future about the health of the patient or some healthcare outcomes that we're interested in.
Fantastic. Well, unfortunately, we have to draw to a close because we've gone well over 1 hour. Thank you very much to both of you, Sandrine, Rick, those fantastic presentations. I think it's been an ambitious hour, an ambitious program. We've covered from imaging the peripheral retina to OCT, angiography, and of course, venous overflow. So I don't think we can cover more today, but we certainly look forward to seeing you again, face to face. Thank you very much. And thank you again to Canon for putting this webinar together and for inviting us to share some time with you. Thank you very much to all of you, and see you soon.